talking about ARDS, also known as Ards, and we'll kind of dive into a lot of that information on what it is, how you get it, and what we kind of should do. So Ards is a severe lung condition characterized by fluid buildup in the lungs. There's these air sacs that are called alveoli, and it makes it difficult to breathe, and it reduces the level of oxygen that you can get from your lungs into your body, and then from the CO2 that's in your body into the lungs and out. So there's a bad thing that happens there, causes a lot of issues. So we'll kind of talk about that a little bit. So some of the common causes are infections, kind of like pneumonia, your sepsis type stuff. Any kind of trauma, chest blunt trauma can do that injures the lungs, and any near drowning type incidences. So you really should be finding medical attention, especially if you really hurt your ribs. And a near drowning thing, you definitely need to go see the emergency room, see the doctor, see somebody that has that medical knowledge to be able to keep you safe, healthy, and be able to make it through the day, the night, all those kind of things. So let's move on. All right, so the description of ARDS, we'll kind of go over that. But first, probably nice to know what ARDS, ARDS stands for. It stands for Acute Respiratory Distress Syndrome. And those alveoli that I talked about, those are really delicate air sacs that are in the lungs that get flooded with fluid. And that makes it to where it's near impossible to be able to diffuse oxygen where it needs to be and CO2 where it needs to be. And that's where we run into a lot of problems. So with having reduced oxygen levels in your blood, it puts a strain on your vital organs. So your brain, your heart, even your liver, your kidneys, all of the vital areas that are able to help your body function and do things that you do normal day to day, it can impair all that and cause a lot of problems. Excuse me. So we need to be able to address all those type of things. And a lot of time, if those things become a dysfunction, and then they come failure, and then ultimately death. So if it's not addressed appropriately, death is what the end result would be. So a lot of the time, people that have ARDS require mechanical ventilation. So that means putting a airway tube, endotracheal tubes, what we call them, down into your trachea and secure that and make it to where this breathing machine, breathes for you. Puts the air in, takes the air out, and then we can change a bunch of different things to make that better and help your body be able to heal that way. So it's just supportive care, though. I do want to bring that up, that everything, for the most part, that we do as respiratory therapists really is supportive of your body, and it gives your body time to actually do the healing. So we're just helping with the symptoms that are showing up. We're not fixing really anything, but we're offloading some of the work, the energy, the physical strain that your body has to go through to be able to breathe, bring oxygen, the CO2 out. And so we're going to try to help offload that work and then let the body heal and do things for itself. All right. Okay, so some of the causes of ARDS. So we're talking about some insults to the lungs. So we talked a little bit about that. Severe infections are a big thing. Any kind of trauma, inhalation of a harmful chemical or even dust, all that kind of stuff. If it's laced with different things or has something else in it, fertilizer, that kind of thing, it can really mess up those air sacs, causing you to be into this classification of the ARDS. So sometimes medications can probably get to that at some point too. There's side effects with those pharmacological things. And then there's medical complications too, like pancreatitis, or even sometimes blood transfusions that just kind of cause there to be a reaction to that. So we talked about how sepsis, which is a life-threatening condition characterized by a systemic inflammatory response to the infection, that can definitely cause ARDS. And then any trauma to your head, chest, or even any body part can also lead to a lung injury. Our lungs are pretty sensitive pieces of organs, and they just kind of have a lot of things going on that way. So some of the risk factors, we'll just kind of talk a little bit about this. So individuals that are a higher risk, advanced age. I mean, that's kind of a common one when you're talking about a lot of these type of things. Any kind of history of tobacco use or even alcoholism. And then pre-existing lung conditions. I mean, we're talking like COPDers, really like severe asthma people too, I'm sure can kind of have a little higher likelihood of this. And then if you have any kind of high risk surgeries that you're going to be going through, they can kind of have this. Flash pulmonary edema is a big thing that can happen. You just sometimes don't know, but really any surgery can have a high risk type of component to it, depending on your health history and all the different things that kind of lead up to it. And then if you've been hospitalized for a severe illness for a while, that can also elevate the risk for you. So symptoms, we kind of talked a little bit about these in the beginning, but they're severe shortness of breath, rapid breathing, an increased heart rate. Kind of the big thing is just really that oxygenation part of it. So where you get the blue in your lips, your fingers, and you're just not able to bring the oxygen in, or you have a lot of oxygen that you're being given. You can only get 100% of oxygen as like the max kind of a thing. And a lot of time you do that with a non-rebreather. So it has a reservoir on it, goes on your face, and you're just breathing in 100% of oxygen. If that's not cutting things, then you're definitely in a world of hurt and need some more, I guess, higher powered equipment to be able to help you overcome that level of your ARDS. So I kind of put this up here. I don't want to talk about it crazy amount. And so I'm just going to kind of read this little definition of what a PF ratio is. So it's your PaO2 and your FiO2 ratio. And this just kind of gives us an idea of some numbers that you can get and see how severe the oxygenation problem really is for the patient. So your PaO2 FiO2 ratio is a critical tool that's used in diagnosing and managing ARDS. This ratio compares the amount of oxygen in the blood, PaO2, and you get it by drawing an arterial blood gas, to the amount of oxygen delivered by the ventilator, FiO2. So in ARDS, the PF ratio is significantly reduced due to impaired oxygen exchange in the lungs. A lower PF ratio indicates more severe hypoxemia and suggests a higher risk of mortality. So if you're on a ton of oxygen, but your ABG PaO2 shows it being really low, then your PF ratio is going to be trash, was what we would kind of call that. So a PF ratio below 300 millimeters of mercury indicates a moderate ARDS, while a ratio below 200 indicates severe ARDS. So monitoring changes in the PF ratio over time helps us be able to assess the effectiveness of a treatment that we're giving, so like the mechanical ventilator, and then we can adjust things accordingly. So the PF ratio serves as a valuable tool in the diagnosis and the severity assessment and management of ARDS, so guiding clinicians in providing timely and appropriate interventions to improve patient outcome. So definitely something that I use, kind of think about, and continuing on to be able to help the next person. So Some of the diagnostics of ARDS is imaging. So chest x-rays are kind of a big one. And you'll just see a lot of kind of ground glass appearance in the x-ray. And then we just talked about the PF ratio being a really big distinguishing feature of that as well. So you have to be able to differentiate the other causes of things. So our heart and our lungs are very tied together. One thing affects the other. And so you got to do the best you can to be able to figure out if it's heart failure or a chronic lung disease, or if it's an acute RDS thing. So clinicians rely on clinical history to be able to help out with that, physical exam, imaging studies, and laboratory tests. So features such as a recent exciting event, rapid onset of severe respiratory distress, and bilateral infiltrates on the chest x-ray favor more Ards stuff. So signs of like a chronic heart failure, it's kind of a long-standing respiratory symptoms, or structural lung abnormalities point towards other diagnoses. So you do have to kind of have to think through of what the patient history is, how long or how fast this ARDS came on, if you think it's that, and if it was something that was kind of happening before, and just kind of going that way with it. All right, so treatment options. Really, we're going to focus on supportive measures. So we're giving oxygen kind of as the first thing to help prevent further damage. So it can include up to mechanical ventilation, but you can't just give oxygen to be able to help out, or like a BiPAP to be able to help out there, or high flow oxygen. So the mechanical ventilator, because it kind of ends that way a lot of the time, really helps deliver oxygen to the lungs and helps pull that carbon dioxide out and makes it a lot easier for the body to kind of heal itself. One thing that you can do, depending on what your PF ratio is too, is proning a patient. So a lot of the time they're sleeping on their back, and then you flip them over to be on their belly, and they're able to oxygenate different fields of their lungs and be able to use different spaces. And so what we find is that as they're on their belly, you can actually oxygenate better, have less FiO2 requirement. But it does kind of come at a little bit of cost, because you do have to sedate people pretty heavily, a lot of time using paralytics, and fluid management's a big thing. Not having too much fluid on board, not crazy. You don't want them too dry, you don't want them too wet, so it's a balancing act there. And then the other thing, and I'll probably end up doing a 10-minute learning on ECMO as well. So extracorporeal membrane oxygenation. Really, it's like a heart and lung machine. So you put in some catheters to pretty much, and I mean, again, I'll have to kind of look into this a little bit more, but to the heart type of thing. And the ECMO machine actually takes over the pumping of the blood through your body. It oxygenates it outside. So it brings all the blood outside, oxygenates it, takes out all the CO2, and then puts it back in and goes all to your vital organs, and then comes back. People are still intubated for this a lot of the time, and they still have that ventilator on there, but it's just kind of there just to help the lungs kind of open and close every now and again. So the majority of the work is the ECMO that's going on there. So, all right, so recovery. So just kind of let you know that a lot of people that do end up having this, really, they do survive, and they're able to kind of live their life for the most part pretty normal. But they're on mechanical ventilation and other type of things for a longer period of time. And, when you're using paralytics, when you're using heavy sedation, your muscles kind of waste away. So it does take some time to recover those by doing rehab. There's pulmonary rehab too that can help. anybody that's had ARDS, so that they potentially can get off oxygen and not have to have that in the future, and get those strength and also, the sense of being able to do what they want and that ability there. So some, like I say, while many of the ARDS patients, they are fully recover, some can experience some persistent symptoms or require ongoing medical monitoring and support. And then, you're also just kind of have to realize that, there's a lot of negative things that can happen with all the supports that we use. So mechanical ventilation, drugs, and all that kind of stuff, it can cause other issues that you have to kind of work out and everything like that. I mean, everything comes with a cost a lot of the time and consequences. Sometimes you don't know what those are until you go through the procedure, the process, and you come out the other side and kind of see how those things. But really, the good thing is that you survived, that you're living still, and that you have a life that you'll be able to live. So I do have some additional resources for everybody, and I'll try to copy this slide and put it into the description so that you can go to the websites and everything like that, or give it to your patients, their families, all that kind of stuff. I think a lot of time we don't give resources to people to be able to cope with the different things that they have to go through, and there's just a list of a bunch of different websites, which I'm sure there's way more. This is just a list that I came up with that gives you some hope, gives you some perspective, gives you some ideas of what other people going through and all that kind of stuff. And then again, like I said, I've just been using the American Lung Association for their information, and it's been really good. But thank you so much. Appreciate everything and all the comments, and I hope to see you here at another 10-minute Learning with Brandon. Thank you.